Welcome. Today we work through dysphagia, the sensation of difficulty swallowing. We will follow one patient from chief complaint to plan and build a simple framework you can use on any dysphagia consult. The goal is a clear map. Where does the problem lie? Is it structural or neuromuscular? And what test comes next? Let us begin. Let me present a patient. A 68-year-old man comes to clinic. His chief complaint: food feels like it is getting stuck in his chest. It began with solid foods about 4 months ago, and it has slowly worsened. Now even softer foods hang up behind his breastbone. Hold on to this one-liner. An older man with progressive solid food dysphagia. Every teaching point today ties back to him. Here is what you will take away. First, define dysphagia and separate oropharyngeal from esophageal. Second, localize the problem from the history alone, before any test. Third, use 2 powerful discriminators, solids only versus solids and liquids, and intermittent versus progressive symptoms. These 4 ideas do most of the diagnostic work, so we build them early and return to them often. Continuing. Fourth, separate structural causes from neuromuscular ones. Fifth, choose the right first test, usually endoscopy or a barium study. Sixth, recognize alarm features that demand urgent endoscopy. And finally, know the headline management for the entities you will actually see. Schottky rings, eosinophilic esophagitis, peptic strictures, and achalasia. Let us return to the case. Let us take the history. The trouble began with meat and bread. Classic solid food dysphagia. Over months it progressed. And now some softer foods stick too. He points to the lower chest, not the throat. He has no trouble starting a swallow. No coughing or nasal regurgitation. But he has lost about 15 pounds without trying. That weight loss is an alarm feature, and we will not forget it. Now the relevant background. He has had heartburn for years and never treated it. He is a 40-pack-year smoker and drinks alcohol regularly. He has no history of stroke, no weakness, no slurred speech, and no known cancer. Notice how this history shapes our differential. Chronic reflux points toward a peptic stricture, while smoking, alcohol, age, and weight loss raise concern for esophageal cancer. We keep both in mind. The exam is focused. He looks thin but not acutely ill. His neck has no mass and no enlarged lymph nodes. His cranial nerves and strength are normal, which argues against a neurologic cause of swallowing. And his mouth shows no thrush, so infectious esophagitis is unlikely. A normal exam does not reassure us here. In esophageal dysphagia, the exam is often unremarkable, and the workup carries the diagnosis. Let us define terms. Dysphagia is difficulty moving food from the mouth to the stomach. It splits into 2 zones. Oropharyngeal dysphagia is failure to propel food from the mouth through the upper esophageal sphincter. The trouble is starting the swallow. Esophageal dysphagia is food sticking after the swallow has begun, on its way to the stomach. Keep dysphagia separate from odynophagia, which is painful swallowing, a different clue we will use later. Before any test, localize with 2 questions. Oropharyngeal patients struggle to begin the swallow. They drool, cough or choke, regurgitate through the nose, or have slurred speech. The problem is at the throat. Esophageal patients swallow fine, then feel food stick a few seconds later in the chest. Ask where it hangs up and when. A throat-level immediate problem is oropharyngeal. A chest-level delayed problem, like our patient, is esophageal. Why care about getting this right? Dysphagia is common and grows more frequent with age. Left unaddressed, it drives aspiration, malnutrition, and weight loss. It also sits at a fork in the road. One path leads to esophageal cancer, where early diagnosis changes outcomes. Another leads to a very treatable disorder like Achalasia or a Schottky ring. So a careful approach is not academic. It protects the airway, nutrition, and sometimes the patient's life. To understand failure, picture a normal swallow. It moves through 3 phases: oral, pharyngeal, and esophageal. In the oral phase, the tongue forms and pushes the bolus back. In the pharyngeal phase, the upper esophageal sphincter opens, the airway is protected, and the bolus enters the esophagus. Then, a coordinated peristaltic wave sweeps it downward, and the lower esophageal sphincter relaxes to let it into the stomach. Every step is timed. Break the timing or the tube, and you get dysphagia. Swallowing fails in 2 broad ways. First, a structural problem narrows or blocks the lumen. A ring, a web, a stricture, or a tumor gets in the way of the bolus. Second, a neuromuscular problem disturbs the muscle or its nerves. Peristalsis is weak, uncoordinated, or a sphincter will not relax. This single split, structural versus neuromuscular, organizes everything that follows: the symptoms, the tests, and the treatments. So we build the algorithm around it next. Here is the master approach, reimagined from the source figure. Start with the symptom. Trouble starting the swallow. with drooling, coughing, or nasal regurgitation, is oropharyngeal. Work it up with a modified barium swallow, plus an ear, nose, throat, and speech evaluation. It then sorts into structural causes, like a Zenker diverticulum or a mass, or neuromuscular causes, like stroke, ALS, or a myopathy. The sensation of food getting stuck seconds later is esophageal. For that, endoscopy comes first. If the scope shows a lesion or inflammation, the cause is structural. If the scope is normal, move to manometry to uncover a motility disorder. Follow the arrows, and every diagnosis finds its place. Now zoom into the esophagus. 2 buckets. And 2 questions sort them. Structural disease troubles solids only. Intermittent symptoms point to a ring, a web, or eosinophilic esophagitis. Progressive symptoms with chronic reflux suggest a peptic stricture, and progressive symptoms alone raise esophageal cancer. Neuromuscular disease troubles solids and liquids together. Intermittent symptoms with chest pain suggest spasm or a hypercontractile esophagus. Progressive symptoms point to achalasia, and progressive symptoms with reflux suggest hypomotility, seen in diabetes, scleroderma, amyloid, and hypothyroidism. Match the pattern to the diagnosis, and you have localized and narrowed the cause before the first result returns. 2 questions unlock the esophageal differential. The first, solids only, or solids and liquids. Trouble with solids alone points to a mechanical block. The lumen is narrowed, but liquids still slip through. That is a structural cause. Trouble with both solids and liquids from the start points to a motility problem. The wave itself is broken. That is neuromuscular. Our patient began with solids, so we lean structural, and his chronic reflux and weight loss sharpen that suspicion. The second question, intermittent or progressive? Intermittent solid dysphagia that comes and goes suggests a ring or a web, or, on the motility side, esophageal spasm. Steadily progressive dysphagia is more ominous, a peptic stricture, a cancer, or achalasia. Layer the 2 discriminators together. Progressive solids in an older smoker with weight loss, as in our patient, reads as a stricture or a tumor until endoscopy proves otherwise. That is why he needs a scope. Match the test to the zone. For oropharyngeal dysphagia, start with a modified barium swallow, also called a video fluoroscopic swallow study. It shows the mechanics and whether the patient aspirates. Pair it with an ear, nose, throat, and a speech-language evaluation. They assess airway safety and guide swallowing therapy. Add endoscopy if a structural lesion like a Zenker diverticulum or a mass is suspected. The priority is protecting the airway from aspiration. For esophageal dysphagia, endoscopy is the first test. It lets you see the mucosa, take biopsies, and often treat in the same session, for example, dilating a stricture. A barium esophagram can help when you suspect a subtle ring or need a roadmap before scoping. If endoscopy and biopsies are normal, the tube looks fine but still will not pass food. Move to high-resolution manometry. That study measures the pressure waves and diagnoses motility disorders. This is exactly our patient's path. Some findings demand prompt endoscopy. Unintentional weight loss, steadily progressive dysphagia, anemia or signs of bleeding, older age, painful swallowing, or persistent vomiting. Any of these raises concern for cancer or a tight stricture, and delay costs the patient. Our man checks several boxes: progressive solid dysphagia, a 40-pack year smoking history, and 15 pounds of weight loss. So the plan writes itself. He needs an upper endoscopy soon. Now the structural causes, starting in the throat. A Zenker diverticulum is an outpouching of the posterior pharynx above the upper esophageal sphincter. It is a disease of older adults. Classic clues: regurgitation of undigested food hours after eating, bad breath, and a gurgling neck. The big danger is aspiration. Diagnose it with a barium swallow rather than blindly scoping, which risks perforating the pouch. Treatment is endoscopic or surgical repair. Several other structural problems live near the throat. Head and neck malignancies can obstruct or invade the swallow. Proximal strictures, rings, and webs narrow the upper esophagus. A large goiter or bony cervical osteophytes can compress from outside, and prior radiation or infection can scar the tissue. The common thread: a fixed mechanical barrier high in the swallowing tract. These are found by direct visualization and the video swallow study. The classic esophageal ring is the Schottky ring, a thin concentric band of tissue at the gastroesophageal junction. It causes intermittent dysphagia to solids, and the textbook story is the steakhouse syndrome, a bolus of meat suddenly lodging during a meal. It is associated with reflux. Treatment is endoscopic dilation to break the ring, paired with a proton pump inhibitor to control the acid that drives it. Simple to fix once you see it. Webs are thin partial membranes, usually in the proximal esophagus. They cause intermittent solid dysphagia, much like rings but higher up. Their classic association is iron deficiency. When you see proximal webs plus iron deficiency anemia plus dysphagia, Think Plummer-Vinson syndrome. It matters because it carries a small increased risk of upper esophageal squamous cancer. Manage the web with dilation and correct the iron deficiency. 3 more structural causes matter for our patient. A peptic stricture is scarring from years of acid reflux. It narrows the distal esophagus and causes progressive solid dysphagia. An esophageal cancer presents the same way. Progressive solids with weight loss, which is why endoscopy with biopsy is mandatory. And outside the wall, a vascular ring called dysphagia lusoria, or a dilated left atrium, can press on the esophagus. Given his reflux, smoking, and weight loss, stricture versus cancer leads our list. A quick but important detour. Infectious esophagitis. Here, the dominant symptom is odynophagia, painful swallowing, more than dysphagia. It occurs mostly in immunocompromised hosts. The usual culprits are candida, herpes simplex virus, and cytomegalovirus. Look for oral thrush as a clue to candida. Endoscopy with biopsy or brushings makes the diagnosis and guides antifungal or antiviral therapy. Our patient has no thrush and normal immunity, so this is unlikely for him. Another odynophagia cause, pill esophagitis. A tablet lodges and burns the mucosa, typically when it is swallowed with too little water or right before lying down. The classic offenders, non-steroidal anti-inflammatory drugs, potassium chloride, bisphosphonates, and the antibiotics doxycycline and tetracycline. The history is the diagnosis. Prevention is easy. Take pills upright with a full glass of water and stay upright afterward. Stopping the offending pill usually heals it. Eosinophilic esophagitis is a cannot-miss cause in younger patients. Picture a young or middle-aged man, often with allergies or asthma, who has solid food dysphagia and recurrent food impactions. Endoscopy may show rings, furrows, or white exudates, but the diagnosis is made on biopsy, more than 15 eosinophils per high-power field. An allergic, immune-driven inflammation of the esophagus. Always biopsy the esophagus in unexplained solid dysphagia, even when it looks normal. Treatment follows a simple scheme. First line is aproton pump inhibitor. About half of patients respond. If it fails, think of the 3 Ds. Diet. An elimination diet removing common triggers like milk, soy, eggs, wheat, nuts, and seafood. Drugs. Swallowed topical steroids. And for refractory disease, the biologic dupilumab. And dilation. Reserved for ongoing symptoms with strictures. Match the D to the patient, but always start by controlling the inflammation. Now the motility side. Neuromuscular dysphagia troubles both solids and liquids from the start, because the problem is the wave, not a narrowing. It arises from abnormal muscle or nerve control of the esophagus. After a normal endoscopy, the key test is high-resolution manometry. It maps the pressure of each swallow, and the findings are graded by the Chicago Classification version 4. This framework sorts patients into disorders of outflow and disorders of peristalsis, which we cover next. The headline motility disorder is achalasia. The lower esophageal sphincter fails to relax, and the body of the esophagus loses its peristalsis. So food and liquid both back up. Patients report dysphagia to solids and liquids together, regurgitation of undigested food, and weight loss. A barium swallow shows a dilated esophagus, tapering to a bird's beak at the sphincter. Manometry confirms incomplete sphincter relaxation with absent peristalsis. Most cases are idiopathic. Treatment aims to relieve the tight sphincter. The durable options, AREP pneumatic dilation, which is about as effective as surgery, and Heller myotomy, a surgical cutting of the muscle. A newer endoscopic option is peroral endoscopic myotomy, or POEM. For patients who cannot tolerate a procedure, botulinum toxin injection, nitrates, or calcium channel blockers give temporary relief. Choice depends on local expertise and the patient's surgical fitness. Chagas disease is a secondary cause to remember. 2 peristalsis disorders cause chest pain with dysphagia. Distal esophageal spasm is uncoordinated. Simultaneous contractions. The esophagus squeezes out of sequence. Hypercontractile esophagus, nicknamed jackhammer, produces very high amplitude contractions. Both can mimic cardiac chest pain, so exclude the heart first. Treatment relaxes the smooth muscle. Nitrates, calcium channel blockers, or phosphodiesterase inhibitors, and a proton pump inhibitor, plus a low-dose tricyclic for the pain hypersensitivity component. At the weak end of the spectrum, ineffective esophageal motility shows low amplitude distal contractions, and absent contractility means peristalsis has failed entirely. These often ride along with systemic disease, scleroderma classically, but also diabetes and hypothyroidism. The reflux is frequently severe because the esophagus cannot clear acid. Treatment targets the underlying disorder and controls reflux aggressively with a proton pump inhibitor. There is no good way to restore a wave that is gone. Let us close the loop on our man. His pattern is progressive dysphagia to solids, localized to the lower chest, with no trouble starting a swallow. That is esophageal and structural. His chronic reflux could scar into a peptic stricture, but his smoking, alcohol, age, and weight loss force us to rule out esophageal cancer. The right first test is not manometry. It is on upper endoscopy with biopsy to see the lesion and sample it. The history pointed us straight there. A few traps to avoid. First, do not skip esophageal biopsies when the scope looks normal. That is how eosinophilic esophagitis is missed. Second, do not blindly scope a suspected Zenker diverticulum. Image it first to avoid perforation. Third, do not dismiss true dysphagia as globus sensation. Globus is a lump feeling without real trouble swallowing. Fourth, never wave off alarm features. Weight loss and progressive dysphagia earn a scope, every time. Here is the assessment and plan. A 68-year-old man with progressive solid food dysphagia, weight loss, chronic reflux, and a heavy smoking history. The problem localizes to the esophagus and reads as structural. The plan: an upper endoscopy with biopsy as the first test. If we find a peptic stricture, dilate it and start a proton pump inhibitor. If we find a cancer, stage it and involve oncology and surgery. The history did the heavy lifting. The scope confirms the cause. Let us recap the framework. First, localize. Oropharyngeal trouble is starting the swallow. Esophageal trouble is food sticking after. Second, use the discriminators. Solids only means mechanical. Solids and liquids means motility. Intermittent is rings and spasm. Progressive is strictures, cancer, and achalasia. Third, pick the test. Endoscopy first for structural disease. Manometry when the scope is normal. And always respect alarm features. They turn a routine complaint into an urgent one. These are the sources behind today's teaching: the American Journal of Medicine Approach to Dysphagia, the Journal of the American Medical Association and Gastroenterology Reviews, the Chicago Classification version 4 for motility disorders, and recent trials shaping eosinophilic esophagitis care, consistent with current gastroenterology guidance. Thank you for working through this case, and I will see you in the next lesson.